Welcome to the Redefine Health Ed podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Enjoy the episode. Okay, hi everybody. So this is episode 6. Episode 6 of the Primary Care PT series. Today we have 3 gentlemen from Samaritan Health out in Oregon. Before we get started, I'm just going to give them a quick introduction and explain their bios. So Dr. Bob Long has been part of the physical therapy community for 30 years, spending the last 10 years as a clinical manager for Samaritan Health Systems in Lebanon, Oregon. One of his first managerial tasks was to improve patient access. And through that journey, Dr. Long connected with Western University of Health Sciences Northwest Campus and George Fox University in the development of a primary care model for physical therapy within Samaritan Health. Dr. Long believes that PT in the primary care setting is the next wave of our profession's future and may redefine our scope of practice. I agree 100%. Moving on. Dr. Dan Jenkins is the assistant manager at Samaritan Health. He's been involved in the primary care program at Samaritan since 2020. And Dr. Joe Mortimer is a Philadelphia native who earned his DPT from Temple University, which I did also. So thank goodness that you're here with us, Joe.
Totally got to represent.
Temple grads represent. Upon graduating, Dr. Mortimer spent 2 years working in Philadelphia in an underserved community before giving travel PT a try. His first assignment was Lebanon, Oregon, and after seeing their biopsychosocial approach and innovative thought process for the PT profession, he decided to stay to help contribute to the MAPS chronic pain program and primary care model projects. Joe is also a co-owner of Soul for CE LLC, focused on providing health education to educators to reduce burnout, something that is so much needed. Thank you all for being here today. I'm really excited to talk about what's going on at Samaritan.
Well, we're excited to talk to you as well. I follow you on Twitter, follow you on Instagram.
Wow.
It's like we're meeting a hero.
Oh, cool. Oh my gosh. I don't know. Far from it. I'm more of a facilitator and a connector than a hero, but I'll take it.
I love that.
So Bob, why don't you tell us a little bit? You've been around Samaritan for a long time. You know what's going on. Tell us a little bit about the program, how it got started, and why you became interested in expanding into this space.
Okay, so basically this started probably about 3 years ago, and actually probably longer than that, but it actually goes back to our MAPS program, which is for our persistent pain people. And we had have a physician over at the resident clinic and who really requested some help with getting access for his patients. And then also it's like he brought up the possibility, can we be alongside them, to see their patients? And so we started exploring that. And so anyway, the journey kind of led to me talking with Dan Kang over at George Fox University. And then Dan's been really instrumental in setting up, helping us set up the program. And between him and Dr. Jeff Halk over at George Fox, they've really have helped us get this program off the ground. So we attribute a lot of our success with our program to just their previous venture with Providence, and basically in that Providence system they had actually tried this procedure this basically this format, and it seemed to work. And but the thing is like Providence, like most places, are a fee-for-service organization, so they ran into some roadblocks with that as well. So anyway, I approached my supervisors and stuff, and they were gracious enough to actually put together a team of people that we could work with. So basically, I had support of the upper management in regard to this, and this is is definitely grassroots of it's more of the grassroots of a value-based model. So this is something that we really wanted to try to focus on as we develop the program. So we actually went to Providence in Walla Walla, and Chris Zika and his
Yeah.
troop there were very, again, we followed it. We kind of went up and Dan and I took a road trip and we spent a day hanging out with them, and it was really amazing. So we were just, we were totally enthralled with that program. So we did a lot of collaboration with him and how they set their program up, and we kind of modeled ours after theirs. And so that's basically how it all got off the ground. And then, it took us about 6 months or so to really get things going. As in regard to getting buy-in from the physicians, we didn't really have a problem with that. We did have to do a little bit of physician training at the front end, and then a lot of trial and error. And we're still going through the trial and error phase. And I mean, nothing smooth about it. But it's very, but the thing is the physician buy-in is amazing, with this particular program. And then the patient satisfaction and the results we're starting to see up, at the, being upstream that far. We've been with George Fox, we've been keeping metrics in regard to this, and we've been doing some clinical research in regard to this as well. And so we want to find it. We're trying to determine what our true value is, and which is, as you know, is really extremely hard to do. It's not anything that you're going to be able to just sit out there, put out there and be able to say this is what our value is, because there's so many. Like in our case, we have different all these multiple insurance companies, multiple physicians, multiple ideas being put into put into the pot, and then so you're trying to figure out who's doing what. It's like when we were trying to determine what our impact was on imaging, and it was like we were showing that we were making a huge impact, but when they went and did the data mining on it from our Epic team went into it, it's going, well, maybe not. It's like we were making an impact, but it was just, I think there are a lot of other variables there, and so it's hard to show that value. So yeah, it's been an interesting journey for us.
Yeah, for sure. So you said a lot of buzzwords in that initial intro, and one of the first ones that I wrote down was so for the MAPS program. Can you spell out what is the MAPS program? Like, what does that stand for?
Well, I'll tell you what it used to stand for, but I think Joel would be the best one to ask about that since he's in the middle of it.
Yeah. So, Katie, I'm actually one of the proctors for that class. What that class stands for is MAPS. So it's Movement, Acceptance and Commitment Therapy, Pain Science, and Self-Compassion. So it's a pain education class focused on lifestyle interventions where people can help to self-manage their chronic pain by learning, ACT is trying to bring in like what are their values to patients, and then how can we utilize movement education about pain science and showing themselves self-compassion to help them get to where their values are telling them to go.
Okay, love that. So needed, especially so needed in the primary care space where we can get at patients kind of the very first time that they're inquiring about chronic pain. But going back to Bob, so this is interesting because you had said that the MD kind of responsible for that program reached out to y'all first to see if you could participate in that program in sort of a collaborative way. Can you explain that a little bit more?
Yes, actually, it was one of our primary care physicians there, Dr. Simmons. He had reached out to me, and basically his take was, how can my patients get to see you? And because it's like in our situation, you have to realize we're a critical access hospital with 25 beds, very small facilities, and we serve a community of about 20,000 people. But then the surrounding community, when we look at our surrounding community, we're probably serving 50,000 people. But the reality is that we've had a waiting list of over 1,300 people trying to get into the front door of the hospital. And so this is it's been an access problem for us. It's been space, it's been been, just trying to get people in the door. The bigger issue is majority of our patients, 72% of our patients are Medicare, Medicaid patients. So private practices really aren't interested in that particular population, and it's not sustainable for them. And so that kind of rests on our shoulders, and which is what we're here for. But from trying to get them in the door, because it's such a huge population base, it's very difficult. And so that was part of the reasoning behind it. And so that was one that kind of was something that I sold my upper management on, was that, it's like, we need to create access. Here's what we're trying to do. If we can make a difference up front, then, maybe some of these people won't have to come into the clinic, which we found about 40 to 50% of people don't have to come into the clinic. And so,
okay. Lots and lots of things here. So the 1,300 person wait list, is that for rehab services, or is that for just any general?
Rehab services.
That's for rehab services. This is a consistent theme across all of the places that I've been interviewing, especially in rural health, is that rehab services, regardless, it doesn't matter if you're in a rural, like, civilian setting, or if you're in another type of setting. I interviewed somebody from the Indian Health Service. They had an 8 to 9 month wait. I think maybe even 9 to 10 month wait before they had PTs in primary care. And then
that echoes ours.
Exactly. And that's insane, because, like you just said, if we get to those people in the primary care setting, kind of the first time that they come in, whether it doesn't matter if it's a direct to PT, or if it's kind of this collaborative team-based model where maybe the physician sees the patient first and then the PT comes in to consult on that patient, or they talk about it. Like you had said, about somewhere between like the 40 and 60% range from all of the places that I've interviewed have said that a lot of those people can do really well with just, like a one-time consult, some education, try a couple of things. If this doesn't resolve on its own, which a lot of musculoskeletal pain does, then here, what's the plan B? Or this patient doesn't belong to us at all. This belongs to the ED. This belongs to rheumatology. This belongs to ortho directly. So I think that, like, the access to care issue can be totally resolved by placing that PT in the primary care setting. So now I kind of want to hear more about how now being in primary care at Samaritan has not only improved the access, but just kind of explain what the model looks like. Is it a warm handoff? Is it a direct triage? How do patients get to you in primary care?
Okay, I'll explain from what our access has been like since we started the program. And then I'm going to let Joe and Dan kind of jump in on that, because they're right in the clinic and they can really give you the meat of what's actually going on there. For us, we just recently, our work queue has gone, since June, we've gone from about 1,300 people, and now our work queue has dropped down to about, I think we were at 460 yesterday. And the thing is that, but this, we can't solely contribute to primary care, but my suspicion is that if we took primary care away from that model, that we would have, that impact wouldn't be as great. And so that we haven't been able to determine whether we've made some changes within our clinic in order to and improving our front desk and our, basically the way that we receive our patients. And so we've made some improvements in that realm. But I think that the biggest thing is still, I think that if we were to take primary care out of that model, there would be a huge impact on us, and so I'm thinking that so that's an area that's yet to be proven, so to speak, but it is an area that's really on our radar. And so, but I'm going to let basically Dan and Joe kind of take over the rest of the question.
Yeah, so I think another important thing to think about is just some of the patients that we get to see over in primary care. When we see them right after they see the doc, we have a chance to kind of just touch base with them and impact kind of the physician's decision about, is this person appropriate for PT? Because I think a lot of times they go in, maybe they're not really the patient's not really that interested in coming to PT, or they had a bad experience before. But we see them and they like us and they're like, oh, maybe I will give PT a try. Or it's someone that's like, I'm not going to go to PT, but what can you do for me today? Maybe we can just give them a couple of things that they can work on their own. And then if they're not better, then they can come back in a month or 6 weeks. So that was kind of it.
That's also a really consistent thing that I have found. And even when I was up at Bellin doing a site visit at Bellin Health in Green Bay, one of the things that they found too is that, because they're a non-revenue generating service when they're in primary care, but what they're finding is they're getting more of those patients that are, where physical therapy is recommended. They're getting more of those patients to actually come to PT because the patients are able to establish like, oh, I'm seeing this person. I feel like I have a connection with them. I feel like they can help me. So maybe I will give PT a try. When some people think, because unfortunately the reputation of physical therapy to the general public is you're going to have to go 2 to 3 times a week for 8 weeks. It's going to cost you all this money with all your copays. And that's not a good reputation to have. I wouldn't want to go either. It's a lot of stinking time. But when you start to see somebody just face to face and you just establish that initial connection, they're way more likely to follow through with actually seeing people in regular therapy if it's required.
And Katie, I think another thing that's important for us too is that us over in primary care, we have, the importance is also our outpatient services, where our outpatient services on average from the photo outcomes are using about half as many visits as the typical average. So that's a great selling point for us, knowing the therapists that are over here at the hospital for outpatient services. And, they don't have to come here, but what I can sell is that like, we're not going to keep you here 3 times a week for 18 weeks and cost you $800 million. We can say like, hey, let's check in every other week. Let's check in once a month. We're just here to see how you're doing, help you along your journey, and having that confidence to know the clinicians here that also practice that value-based care, biopsychosocial care is so impactful.
And to add to that, Katie, to add to that, to what Joe's saying is that when we, that's one stat that we did pull up, and it was when we looked at the people who were referred to physical therapy from primary care, their average visit was about 4 visits. The national average for photo is 13.7 or something like that. Our clinical average is around 7. So it's pretty significant, so it's like as therapists, we're not trying to hold on to them. We got too many people to do that. So
that's amazing. And I think that like, I wonder, and this is something that, big research people that are bigger and smarter than me can figure out, but I wonder, because I think a lot of people know this part of my past and my history. I started working for a clinic just like part-time, just to try to get like some additional hours here and there. And their complaint of me after 3 weeks working there was that I wasn't seeing my patients frequently enough, and that they wanted me to see my patients 2 to 3 times a week for 14 to 16 visits, because that's how they were going to turn a profit. And I said to them, no, I'm going to do whatever is medically necessary for the patient. I can help you build your revenue in other ways. And then they fired me, like without explanation, without warning. This all took place last summer in 2021. And so that's my expectation of what physical therapy clinics are doing nowadays. So I wonder how different that would be if you changed the business model. So did you say that your hospital system is value-based?
Well, we're trying to be more value-based. It's like we're trying to prove the value of our therapy services. And I think that, that goes on to a whole different discussion, but it's like, I feel like hospitals in general, when we look at what we actually get reimbursed, we really have to consider what is our value, because it's like, it's for us at the end of the day to pay for ourselves is rather difficult, But with that being said, though, I think that it's like we are fee for service, within the clinic. It basically behooves us to get the patients in and out the door, and
especially when you have a wait list that that significant. So what my whole thing has always been, let's flip the scenario. If we can see more patients and do those initial evaluations, kind of increase the number of evals versus the number of treatments in any given day, your reimbursement, even in a fee-for-service model, is going to be better because you're going to get reimbursed better for evaluations. So if you sort of flip the bill a little bit and you see more of those consults, those evaluations, you're not going to have to worry about keeping patients, just from like a business perspective.
Right.
So speaking of that, not talking about your traditional PT clinic, but when you're in before I get to like the end game, the reimbursement, how we get paid, let's actually talk more about what is the model of care. So the patient calls, they have a problem, or they're coming in for their annual visit with their primary care physician or provider. How do they end up getting to see a PT in that same space? Is it co-located?
So basically, we're not co-located. It's like our PT office is across the street, but Joe and Dan are embedded, or we have therapists that are embedded in that clinic. And so when we set up that model, we set it up so that the therapist, there would be a therapist in that clinic all day. But I split the models because I split it because it's a split day for them. So they'll spend half a day in clinic here and half a day in clinic across the street. And I did that on purpose, just so that I didn't want anyone just being the primary care physical therapist, because then they lose touch with what's actually going on in the clinic and who's able to provide what services. And so what we have to think about is that these people are actually gatekeepers. It's like they're performing guided access. Like in the military, how you have guided access to get services. It's like they're doing kind of the same thing. It's like what they're doing is they're saying, hey, I've got a pelvic floor specialist. We can get you into that person. Or I've got, or it's like Joe, for instance, had a case where they had a warm handoff from the physician to him to mental health, and so they're able to we're able to get people to the right place, and it goes back to right place, right time, and but that's kind of how our basic model set up. But I'll let Dan and Joe kind of explain what goes on in the clinic from the clinic aspect, because things go a lot different than what I put down on paper for them.
Okay.
Yeah. So at this clinic, it's a family medicine clinic. There's residents there, so they always have kind of a rotation of who's there and who's not. And basically, the patients will come in, they'll do their visit, and then we call it a warm handoff visit. It's billed incident to, so basically any charges that we drop, the physician gets credit for. And then the other thing that's interesting is that we're actually on their payroll, so they're paying for us to be there. It's not coming out of the PT department's budget, which is a really smart way for Bob to get that set up. And so then the doc or the MA will page us, and then we'll go see them, and then just collaborate with them and talk about what the patient needs, where they need to go. One really cool thing is, having a PT like Joe on staff. He's done such an amazing job, just like becoming friends with all the providers. And one thing that's kind of, I think, a unique challenge of primary care is if you're only seeing someone for 20 minutes, you really have to be able to build a rapport really, really quick. And so like the PTs that we have over here, like Joe, they're able to do that in just it's such a fantastic way. Like I don't know a lot of PTs that are able to do that, but.
So Joe, tell us a little bit about your experience then, because I have always advocated for, like, it really does take kind of the right person, the right personality to be in this space. So tell us a little bit about that.
Yeah. Thank you for all the kind words. I didn't pay them to say that, so that was very nice. I think a lot of it, the rapport building with providers came from a place of just seeing the things that they are struggling to help patients manage, and the tools that we have to help them with that. And what really helped me is at Temple, I had a great starting seed planted for like chronic pain and pain science stuff, right? And it's not just like, let's just explain pain and that's it. It's that has morphed into this MAPS program that I saw here of them actually taking group classes through things that are meaningful for patients that can help them grow as people and ways that they can manage it on their own. And I see providers trying to give and give and give and give, but we need to, I think a lot of the time now is trying to help us shift that to the patient to help them self-manage their symptoms. So I see a lot of providers just like spinning in circles, like how do I help this person? And for me, it was kind of sharing that knowledge with them of like, I'm here to try and help them help themselves. And I think we can help with that. So, also, how are you doing as a person, right? I think a lot of this was like me genuinely just caring like how they are, because they're people in like a difficult situation, right? Like our wait list was very large and has shrunk a bit, but like, they got 6 months for like new patients. Like their wait list is huge. It's an endless sea of stuff coming in. So what things can we help you with? And especially with chronic pain, it is a tough thing it's not a fix. It's a management thing. And being able to come to them of like, hey, these are some tools that we're using in the clinic. I think you could also use this in your life too. What kind of benefits do we see from that? And just growing that connection with them. And then, I've had a few connections with those providers outside. A big thing for me is trying to build, and what Dan and Bob have done an absolutely fantastic job of, is building a sense of community within our department. So we have a lot of clinicians that are along the same belief pattern about, value-based services, patient self-management, and making sure that we're looked as more of like a coach, not necessarily a fixer. So I wanted to try and continue to grow that. So I started this second Saturday program where like every second Saturday we pick something fun to like bond as like a clinic. And I also started inviting providers from the primary care clinic, and you get a few of them coming in and you kind of grow this little community of people caring for people. And I think that is what's really helped this program continue to flourish.
Joe, you have the magic. So like, I'm serious, like there really is, there is magic to be found in people who really truly understand how to connect with other people. And one of the things that we talked about in episode 4 with Rusty Bishop from the Palo Alto VA, he one of the things he said was, because I always ask, like, how did you start the program? How do you get the buy-in? How do you like, do the convincing of the powers that be? And a lot of times it really comes down to just developing relationships, being friends with somebody. If you're in the break room, go to their break room for lunch, get to know them. And then they get to know you and they experience like, hey, not only is this person really highly skilled and they know what they're talking about, but they really genuinely care about other people. They really genuinely care about their patients. They want their patients to get better. They want the whole system to work better. There is magic when you have that.
Yeah.
So kudos. I think that's awesome. And I think that is something that I'm hoping more of the world will do, is to like have more of these. And I really think it starts in education, because IPE, like that's another little buzzword in education and academia right now, interprofessional education. There is a lot of magic that takes place if there are, in our fundamental training, if there is opportunities to collaborate with the medical students, with the PA students, with the nursing students, OT, like if that happens from a foundational level, that only will have this trickle effect and break down those, those silo walls that keep us in, we're the PT clinic and we're the primary care and we're the whatever. So what do you think, like, that's an awesome place to start. What would your recommendations be to other people who are looking to, they don't have this model, they're sort of like traditional to a T. What would your recommendations be for them?
Are you asking from an administrative standpoint or from like a clinician standpoint?
So like I'm a PT, I work at XYZ hospital system and I work in my PT clinic, and maybe I'm the PT manager, and I really would love to break into the primary care. I would love to get embedded into primary care, but I don't really have any relationships with any of the providers over there. What do I do? What are my first steps?
I think something that I've seen that has worked very well from Dr. Sharna Prasad. So she's actually the lead for the MAPS program and also the co-owner of Solace, the other program that I have outside of this. She just invites providers or even MAs or care coordinators, just, hey, do you want to grab a bite to eat at lunch and just like get to know them as a person, right? So it's just like a lunchtime break to build a relationship with them. That's not something I've done myself that much of, but I've seen that work. And I also know that Dr. Simmons, and who was the one that initiated more of that push for the primary care to be in there, like he's just a sociable guy that's down to have a lunch with you and just like, how are you doing as a person? Like what cool things can you offer me? What cool things can I offer you? And just building a rapport from there would be probably the first starting block.
Okay, awesome. So now going into like, I want to hear about more of the research that you're doing, but just anecdotally, what have been some of your experiences of the advantages of being embedded in primary care?
I think one thing I see a lot of, which was kind of like a little bit more of a pleasant surprise, is the impact on BPPV patients that like, man, talk about like a one time, like this magic thing that we can do that like now they're not dizzy, but instead of them being on like meclizine until they can get into a rehab clinic, until they can do like all these other things. So that was a big advantage for me that I saw, because I have a little bit of a vestibular background. I'm by no means a vestibular specialist, but I'm very comfortable treating BPPV, as I think most clinicians should be. Like it's something that we can get in and out very well, and that's like value-based care for me. It's like, oh man, like one visit, and I'm like, we're good. Let's do this.
Yep.
So that yeah, and then like another thing too is just the overall collaboration. So we had a meeting on Saturday with a bunch of the PTs that are at our clinic, some of the other administrative like advisors, and then a few physicians. And one of the physicians was a physician that is attached in our program, and her big thing was just like, the advantage of just having a warm handoff system that's collaborative with them to like decrease that silo. Because it sounds like, even there's about 8 clinicians. So we have about 4 MDs, a DO, a PA, and 2 NPs, plus 6 to 8 residents that are kind of like cycling through there. So like, even though there's all of those people in the same clinic, I get the sense that like you still feel a little siloed. You're not really able to like converse about like what's going on with the patient. So just that other clinician second opinion interaction in the clinic helps to build trust in the healthcare system, helps patients build trust in the healthcare system. Like, oh, we got a built-in second opinion here. Like that's really cool. That like one-stop shop. Now, granted, sometimes it's a long day that they're there. Sometimes if they're running labs, if they needed an x-ray, if they needed a few other things, they can be there for an hour and a half to 2 hours. But that's where we come in, and it's like, let's make this fun. Let's bring some energy and help collaborate to help you get better.
That's awesome. And that 1.5 to 2 hours, if that was broken down into multiple visits, that is a lot more time with people. I mean, I'm like a busy person. I've got 2 kids. I've got a business. I see patients on the side. I got a dog snoring behind me that always bugs me for a walk at noon every day. And I am busy. Like, I don't have that extra time. So if I have to get out for an appointment, like I want to make that, like, I basically have to block my whole morning or afternoon anyway. So if you can make that like the most optimized appointment, then people are going to be appreciative of that for sure. Any other cases or like, even just like, patient experiences that you want to share? If not, we can move on.
I mean, how long do we have? There's plenty of like really awesome things that we've done. So like I'm gonna step back from the mic. Like, Dan, is there anything that you felt like, because like Dan is now also like, we're here in Lebanon, but we also have a clinic in Sweet Home, which is another smaller town, like satellite, that they also have primary care, that Dan's been working more on trying to get that system like up and running a little bit more. So Dan, do you want to share some of that
please,
stuff?
Dan, jump in.
Yeah, just yesterday. So I had the provider come and grab me and say, hey, I got this guy. He fell a week ago, and his shoulders kind of messed up. So what do you think? Come take a look at him. And I think one thing that's really different from primary care to outpatient is just like, I feel like we have to wait so long to see some of these folks. And like, I was able to just kind of figure out, like, this guy, he's got a full thickness rotator cuff tear, and I don't think PT is going to be of any benefit for him. So like, let's just send him straight over to ortho. And I think the doc was kind of leaning more towards, let's just get him to PT and see if we can rehab conservatively. But I think, being a PT, we are the best people to know where do people need to go, or at least will they benefit from PT or not.
Yep.
And so, yeah, I think, like, I just want to echo what Joe said about collaboration. I think that's become like kind of the primary, like, the important reason, like, that we're there, is to collaborate with the providers and deliver like the best care to these patients.
Awesome. And that's going to save the patient so much time and money, and frustration and delays. Like I've seen a number of patients like that. I remember seeing this patient when I was in the Army, and I think I talked about this one case before, but it was just so shocking. When I was in the Army, I was embedded in a soldier center medical home at Fort Sill, and I had this one patient come in from sick call, and that's like either patients, getting injured over the weekend or from the day before, or actually during PT that morning, physical training. And one guy comes in and he like can barely, he's like, I screwed up my shoulder. I don't know. I screwed it. It's really messed up. And all I had to do, like, he couldn't really move his arm, but all I was just like, you got to take your shirt off. I got to look at your shoulder. So he like could barely get his shirt off. And I just looking at him, I was like, okay, he tore his pec. There's nothing I can do for this patient right now. Like, I could see the defect in his chest. And I was like, you tore your pec. Like, let's do it. I had the ability to order an MRI, and I just called up my ortho buddy and was like, hey, he's coming. And just got him like up to ortho like that same day. And imagine what would happen if that patient, maybe just saw primary care. Maybe they didn't have him take his shirt off. Maybe they just thought it was like a little shoulder tweak and referred him to therapy, and then he had to wait. Like, that could lead to some pretty poor outcomes.
Yes.
For that patient. And like, imagine if that patient was trying to walk around, like, having to get dressed every day, having to like go back to duty, like what would happen? So I think a lot of people, there are just so many benefits from, I'm obviously biased, but there are so many benefits for PT being in this space. And you just echoed that. So now just in like, we're kind of getting close to the end of our session here. So I just want to make sure that other people have a good, clear understanding of how you are billing and how you are being reimbursed. You did mention that you're on family medicine's payroll, which I think is awesome. And I think a lot of people need to explore that, because I think a lot of people are worried about, hey, if we're doing incident to billing, how is the physical therapy department or a physical therapist who's been being seen there, how does that all make sense for the budget and the finances on the back end? So explain a little bit about that.
So when we're looking at when you're looking at the incident to billing, it's like we receive nothing on that, but it's like that goes back to value based, So one part of the thing that we have here at Samaritan is we do have basically kind of our Medicaid program that is capitated. And so, and basically when you consider that 25% of your patients are on that program, it behooves us to try to save them money. But also it's like when you look at Medicare, the reimbursement rates and issues coming out around Medicare and the possible MIPS for hospital-based systems and that, it's like we need to really look at what value we bring to the table. And that's what I was alluding to earlier, is that fee for service isn't paying our wages too. And so anyway, so anything that we can save in imaging, anything that we can do to improve the patient outcomes and, decrease, 30-day readmits or basically, or any type of readmit, and improve the patient health. I think that puts, that really helps that picture, that financial picture for the hospital and, for our system. But when we're looking at what we actually get reimbursed, is like I said, we get nothing from the physicians. The reason we had to go that route is because of rural health rules. And so we had to be part of that team, which turned out to be a godsend for us, in that sense. And so it's so basically, or from my standpoint, all I have to do is make sure that I have someone when I send someone over to the physician's clinics or to do primary care, I need to have someone here seeing patients. So it's increased the number of people that, basically Dan and Joe can both attest to the number of people that we've actually increased in clinic because of this. But we went from a staff about 16 therapists now, but this is because of other programs that we've started as well. But we're now to a staff of 22 therapists, and it's we have a fairly large staff, but we're paying for ourselves, and so it's but when you start looking at things, though, it's like when you're seeing people up front, in that upstream, that spot upstream, it's also by what we do for them upstream. We're creating a value where we can offer more services, and reasoning for offering more services like pelvic floor, pediatrics, and it's like, and we have those services here in this little hospital, and they're not just a small department, they're a big department, and that's we got those these extra therapists that we have on board. And so there's that. Our MAPS program, that's basically, that MAPS is actually what started this whole program, and from that standpoint, but having places and programs to, we have to develop places and programs for our patients to go to.
Mm-hmm.
And then I know that Dan's been very instrumental at, getting out to the community and seeing, what's available for our patients out in the community, and so we have to, it's like, we're not just a hospital now, we're a community-based hospital, and we're roping that community into our system. So that's how we find our value, and we end up paying for ourselves. And it's just, and it's, when it goes to billing, we're billing basically, we're billing for exercise, we're billing for self-care, we're billing for neuromuscular activity, and an occasional manual therapy. And so it's, but what we actually see reimbursed, some of it doesn't reimburse. So it's like, currently I've been to meetings with insurance companies because they're requiring prior authorization, so it's like, it's that evil prior authorization just because they saw PT on the bill. And it's, but it's like, we're there side by side with the physician, and what are we going to authorize? So I've already had one meeting with Blue Cross Blue Shield, and they seem pretty much in favor of what I had to say. So and then I have another one with MODA later on this in December. I have one with MODA, and so
I love that. You're just like taking the bull by the horns and, explaining what you're doing. I think a lot of people just sit back and say like, oh, it's going to get denied, so that's it. We just won't do it. But I've always thought about that. If you actually reach out to insurance companies, explain what you're doing, explain the new model, then, they very well could be like, oh, that makes a lot of sense. That's probably going to save us a lot of money. So why don't we just do that? And so this is like, I've gone around in circles about this topic. And I was like, well, just because it's the rule now, it just means that there's probably a disconnect. If we know that it's probably going to save the patient money, that means it's probably also going to save the insurance company money. So let's tell them about that, because that makes sense for their bottom line. Again, everything's a stinking business. So yeah, that is really interesting. I want to hear a little bit more about that. And I also want to hear more about some of the research that you're doing. Do you have any plans to get stuff out there in the next, I don't know, year or so?
Well, basically, with the research on the research end, like I said earlier, it's like we've been running data on basically we've been looking at our primary care model from the standpoint of what are we doing with opioids, what are we doing with imaging, how are we impacting that, what is our utilization like. And so we just at our retreat this weekend, one of the things that we were looking at that data, and we actually ended up saving there's like a 6% difference in opioids. So but overall we were there was a 33% decrease in opioid use from when they were seen in the primary care,
Wow.
the primary care PT versus those not seen by the primary care PT. We saw a decrease in injections, but it was only like 1%, 1 or 2. And it was, but it wasn't significant enough, to say that we had an influence on, in that particular arena.
Mm-hmm.
One of the problems in our system is that's also one of the ways that physicians are reimbursed. It's part of the reimbursement model is, so the
more procedures you do, the more money you're going to make.
Yeah, exactly. And so, and then on the other thing though, is we looked at imaging. So when we looked at, general X-rays, we saw an overall decrease initially in our results. But when they did the data mining, they said, no, it wasn't that, that the hospital was already in a downward trend. But the thing that I did notice is that when we looked at utilization, those who utilized us the most had the least amount of X-rays or least amount of imaging.
Mm-hmm.
Those who utilized us the least had the highest amount of imaging.
Mm-hmm.
So that was, to me, that was fairly significant.
Mm-hmm. And I think it's also important to take into consideration is the utilization of imaging reasonable or not? So, because that, there's in my partner, Lance, my partner at Redefine, he does all the imaging stuff. And one of his biggest things has always been, we don't want to discourage imaging if it's actually needed. Like if somebody hits their head against the ground and they meet the Canadian C-spine rules, we should probably order an X-ray. So exactly. So building that into those research metrics, which is difficult to do. And a lot of this research, a lot of the data is going to be difficult to collect, and it's going to be difficult to analyze because it is so multifactorial. So potentially even including more qualitative studies on just the experience of the patient going through that type of model. Are you considering any qualitative type studies?
So we've kind of done that with our physicians. Joe made up a questionnaire for the physicians, and it's like it was 100%. They were totally in favor of us being there and all of that. One of the tools that we utilize is press gaining reports, and we had some that were shared with me by the clinic managers, and there were a couple of them that were just that kind of really stood out and that I've used in presentations. But it shows that they both echo the same message, and it's like I was seen in primary care. I was surprised that the PT was able to come in and help me. I was amazed at what they were able to do. And then the other thing is it saved them money. It saved them time. They didn't have to go back. They didn't have to pay an extra copay. Everything is like everything that we've talked about in, here today, that's what was echoed, by these patients. And so, and this is kind of a common theme that we see across the board. And so, that's, when we look at value-based and patient-centered care, we're hitting that one right on we're hitting that one right on the head.
I love that. So in closing, I just want to kind of open up the floor. Is there anything that you want to say to our potential listeners, which probably our listeners are going to be more along the lines of people who already have implemented this model and they're looking for different ideas, or people that are interested in implementing this model? So I'll just open up the floor. Whatever you want to say about primary care PT.
Well, I'll say something. I'm going to have to scoot because I've got another meeting I got to drop into.
Sounds good.
I just encourage everyone, those who are interested, to try it. It's really something that I think it's our future in physical therapy. And that's, it's like I've spoken at Western University and George Fox. And of course, George Fox, they're already there. Western is kind of, the students are getting exposed to it via us. But, it's like I really encourage people to start exploring that avenue. And that collaborative care that we do with physicians is just amazing. It's like, we always, it's like we've been told, we're the best at doing this and this and this, but we've never gone out and shown that we're the best at doing this and this and this, and so it's like, so in this case, I feel like we need to collaborate. We need to be on board with work with those physicians, show them what we can do and show them how we can help. It's not as like this is what we can do, but this is how we can help you. And I think that's the message that we have to bring across the board, because that's going to prevent burnout from both sides. It's like we get burnout on our end. We have our patient loads. I worry about my therapist being burnout. But this is like when you're working with people and you all have a common goal, it makes a huge difference.
It brings life to the room. And that is something that everybody has shared. And there is actual research that shows that. Dr. Long, thank you so much for being here. Just so everybody knows this, Dr. Long is actually the co-chair of the APTA federal, the primary care special interest group, which is under the APTA federal. So Bob, I'll see you later tonight.
Yeah.
You jump off for your meeting. Go ahead.
Okay. Thank you.
Yep. So Dan and Joe, what are any parting thoughts, any words of wisdom, anything you want to share about your experiences, especially, being in the field a little bit? You're not really, well, you're maybe relative new grads, not really, but in the 10-year-ish range.
Yes.
I'm throwing assumptions out there for Dan.
Sure. I think, primary care, it's a risk, and it's not like the safe traditional, outpatient PT that a lot of folks are just used to doing and comfortable doing. And I think we've realized that the model needs to evolve along with our skills. And it's, like I said, it's risky, but it's definitely, we've proved that it's worth the risk. Mm-hmm. So we definitely just have to go for it.
Agreed.
And then to kind of echo what Bob was saying, it kind of takes a community of everyone being together. It's not just Dan and I in the clinic. There's Dr. Paige Burkett, Dr. Michael Wong, Dr. Mitchell Prunk, Dr. Brianna Becker. We're trying to get her involved a little bit more. Dr. Bill Walters was previously involved in Sweet Home. So there's a lot of people that are not on this podcast that have so much to do with the success of this program as well. And us being, Bob has referred to us as kind of like the boots on the ground, and you're going to see some stuff, and it's our job to try and bring that to light. This is what our patients need. And sometimes it's not the easiest thing. Sometimes it's not just like an ankle pump. Sometimes it's let's get you over to a behavioralist, or we got to get you into mental health to try and help with some of these things. So there's a lot of factors that can be at play in what is affecting someone's pain and their overall function. Mm-hmm. And then the last thing too, I received a lot of compliments and I'm very grateful for them, but it's not easy. Don't think that I wasn't anxious about starting in primary care. Don't think that I wasn't self-conscious about having to go up to providers and explain my thought process about these things. But the more I got to know them and the more I got to share, the more I realized I have a better idea of what could help this person right now within my scope than they do. So we're here together. We're here to be a team. It's okay to be vulnerable with each other. It's okay to not know something and ask. Thinking about it as a teaching experience for everyone involved is maybe a little bit more of the mindset to have. And it's something I'm continually working on. So it is not just sunshine and rainbows over here in Lebanon. We got some rainy days for sure. But it's a testament to just in talking to continue to boost this program. In the last 4 weeks, we've had our 3 busiest call weeks overall, averaging almost 9.5 patients throughout the day in a clinic that sometimes is seeing only 70 patients, and we're seeing over 10%. Our 10% of the patient caseload is what we're thinking is about what our call will be for the day is typically our rule of thumb. I think yesterday they started off with 111 patients on the list, so we would figure about 11 patients. We saw 14. So it's come with a lot of time, a lot of trust building. So it's not necessarily that, Dr. Jeff Halk had shared that with me. We're not necessarily providers are very smart people. We're not necessarily reinventing the wheel. I think they know a lot of this stuff, but can we build the trust to hand that off to us to then keep that in our wheelhouse and go forward from there?
Totally. It's a culture change. It's a culture shift. Yes. Away from, here is family medicine and they you go there first and then you go to the next person, and it's more of building a team. And even a lot of physical therapists are not comfortable with that. You would be surprised at the number of therapists that are presented this model and presented with the opportunity that are like, nope, I don't want to do that. I'm surprised.
I was there. I was there in the start when Dan first presented this to me. I was like, oh man, like deer in headlights. Like what am I able to do this? Yes.
Yeah,
yes.
exactly.
So I totally hear that, Katie. And
a couple of the professors from George Fox, that's what they said, is like medical providers, patients, like community, everyone is on board with this, but the biggest pushback has been from therapists.
Isn't that interesting? And I find
crazy
that so how many years have I been out from school now? Almost 9. So I graduated in 2014. I have found that PTs are our own worst enemy. And our profession is like desperate to move forward. I think the rest of the world, the rest of the communities, other healthcare professionals are desperate for us to step up and move forward. And we're just always like, is that in our scope of practice? Do we have to change the Practice Act? What's the regulation on that? Blah, 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 blah. And I'm just like, nope, let's just make it happen. Let's just make it happen, because this is the right thing to do for society. This is the right thing to do for our population health. This is the right thing to do for the patient that's in front of us, is to work as a team. And teams work better when they're in the same space and when they can work in the same space at the same time. So yes, all of that.
And one last parting thing, like, I think it was something that came to light a little bit more this weekend of like, instead of the first line of defense, like, why don't we be the first line of offense for people? Like, why, like primary care to like encourage wellness in people? Like, what? Like, well, can we get ahead of the curve a little bit more? Like, can we help people understand the things that impact their overall health and their well-being? And we have so many of those tools. Like, that's overwhelming though. That's overwhelming. There's a lot that could be at play. So it takes training, it takes work, but like, let's be the first line of offense. Let's try and push for health and wellness and like help out those that need it as they come.
100,000 million %. Couldn't agree more. This has been a great episode. I know y'all probably have, it's earlier for you out there on the coast. So I know y'all probably have patients that you got to see and everything. Thank you so much for taking the time to do this episode. I feel like we could talk for hours. But just, to respect our other people. Thank you so much. And this one will come out in January.
Awesome.
So,
looking forward to it.
Yes, Katie.
Katie, thank you so much.
All right, guys, have a good one. Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.